Said, I'd like to thank Dr. Vijayakumar and 3DCon for having me here today. I'm going to be talking about the impact of physical activity in diabetes outcomes. We had such a fantastic talk or just before this, and I'd like to add some to this as well. I have no conflict of interest to declare, but there is unpublished data in this presentation, so do not copy this in any way. So this is a paper, the WHO release of physical activity and inactivity patterns across the world, which came out very recently, and India is also part of it, in which they showed from the year 2000 and projected unto 2030 onwards, it looks like physical inactivity is constantly rising. We do know that diabetes is rising. Take one step back, obesity is rising. One step back, physical inactivity is rising. Okay, so this is no big discovery. But look at South Asia. Okay, and here you have men and women, and the women are in pink. You can see that's right on top there. The physical inactivity is rising a lot. But let's look at India in particular. This is a publication from the ICMR INDIAB study, which is a national study on metabolic disease and NCD in this country. And if you look at the number of people who are physically inactive across the country, urban, rural, male, female, however you want to look at it, 60 to 70% of the country is inactive, right? So if you look at urban India, 70%, is anyone surprised? When you say 70% of urban India is inactive, even if I ask around this room, I'll find how many people are inactive right now. But even in rural India, you have this image of rural India in your head where everybody's in the fields walking around behind bullock carts. Well, not anymore. 1 in 2 people, even in rural India, are inactive. If you look at it by men and women, now this is another slide which oftentimes, I feel very ashamed to show. Number of people who meet the physical activity guidelines are 10% in men and 3% in women. Horrible, just to say it in a very, a nice way. So what happens if you do less exercise? You get more diabetes. Again, really not rocket science. So I start off by saying diabetes, obesity, physical activity. Okay, so I think what is important to remember is there are 2 separate concepts here. One is physical activity and the second is exercise. Oftentimes we confuse all of this. Now what is physical activity? Physical activity is any bodily movement that is above rest. Okay, so if I shake my hand, walk about, go here, go there, go to the market, come back, how active is a person is the question you're answering with physical inactivity. Now exercise is a type of physical activity that is structured, repetitive for a purpose, usually aimed at increasing fitness, etc. So everything that you can think of, you're walking, running, dancing, swimming, whatever you take, these are types of exercise. Now, what does exercise do in a normal individual? Let's look at glucose metabolism in a normal individual. When you start exercising, walking, let's say, okay, what happens? Muscles are contracting. The first thing that you utilize is muscle glycogen. So for energy, muscle glycogen starts getting used up. In about 5 minutes, you will utilize those. And after that, you start pulling from the blood. You will pull glucose, you will pull NAFA, free fatty acid, all of this you will pull from the blood. After you have exhausted that in about 15-20 minutes, then you start looking at hepatic glucose output. So glucose, glycogen is first gone, blood glucose has been pulled inside. Once the blood glucose levels start dropping, your liver will immediately start doing gluconeogenesis, hepatic glucose output starts coming, and blood glucose levels are maintained in euglycemia. So it's very important to understand that in a normal individual with normal liver function, it's extremely rare to get hypoglycemia. Okay, so only once you are diabetic or you have a severe liver disease, then you start thinking about hypos. Now, what are the types of exercise? What are the acute and chronic effects of exercise? Now, there are 2 types of exercise. The first is called aerobic, right? Anything that utilizes oxygen. So what we spoke about, running, swimming, dancing, cricket, all of these things that make you utilize oxygen is aerobic activity. Please note that aerobic activity gives you the acute benefit of exercise. What is the other one? The other one is called strength training, muscle building. anaerobic. All of these have a similar connotation. Now, whenever I say this, people immediately start thinking, oh, muscle building na Mr. India. It's not that. Muscle building is for everybody of every age. And the more you build, it will give you the chronic benefit that we are talking about in terms of metabolic benefit. So what happens when you have the acute benefit of exercise? We just spoke about it. Glycogen breakdown, glucose lowering in the blood, and thus you start getting a lowering of your blood glucose levels. Now, what are the chronic things that you get from resistance training and things like that? Here you have the effect on skeletal muscle, adipose tissue, pancreas, liver. So what happens? Think about it. A muscle that is trained is bigger. A bigger muscle utilizes more energy, glucose, oxygen. So it's like, if you say it very simply, it's like this room. Suppose outside there are glucose molecules. The bigger the room, the more glucose molecules can enter into a bigger muscle. So even at rest, when your muscle is at rest, it will utilize and pull more glucose from the blood into the muscle if it is trained and big. Second, increase in capillary density, blood flow to the muscle, oxygenation, all of this helps in the glycolytic cycle. Things like biochemical changes, the GLUT4 increases. So the more transporters come, more glucose is pulled into the muscle. Insulin receptor, increase in hexokinase activity. All of this will help in muscle glucose extraction. In the pancreas, it prevents this hyperinsulinemic attacks that we get due to adiposity. Overall, adiposity comes down due to usually the acute effects of aerobic activity. There's increased glucose uptake, increased clearance of free fatty acid, decrease in the overall gluconeogenesis, and thus blood glucose comes down. So you can see there are two arms to this. One is the aerobic arm, which is the acute effect, the strength training, which is the chronic. You need both in order to activate all of this. So what are all the other benefits? So what are the benefits of exercise for diabetes in particular? At every stage in the glycemic forum, we have the effect of exercise. It's preventing diabetes. If you have diabetes, it's maintenance of good glycemic control, prevention of all of the complications, as well as additional benefits. So do we have evidence to show that exercise can prevent diabetes? We have plenty of evidence to show that exercise prevents diabetes. It started with the Chinese study, Da Ching, and moved all the way up to us in India. We have the DCLIP study, which talks about the benefit of exercise. So here you have both the effects of aerobic as well as, so together, lifestyle, diet and exercise were done. In all of these studies, they took high-risk individuals. Who are high-risk individuals? Those with prediabetes or obesity. They gave this lifestyle intervention and then looked at prevention of diabetes. Now look at the risk reduction here. Some of them have also added metformin. So look at the risk reduction. You will see that exercise has a fantastic reduction more than diet. Intervention, overall 58% reduction. Lifestyle is 58, metformin is 31. So here's the effect. It has more effect than metformin in prevention of diabetes. So go all the way down, you will see the same story. The story we're telling is lifestyle is the most effective thing in preventing diabetes, even more than metformin. Now, is this durable over time? Today we have data, 30-year data from the Da Ching that shows even today. So what happens when you're in a trial? You have the separation of the lines. When the trial is over, the lines come together. But even then, even 30 years later, the effects are separated. Those who did the lifestyle intervention have less diabetes, less microvascular disease 30 years later. The metabolic memory thing that we are talking about. So that's what we have. Now, what about outcomes? So this is for glycemic control. We have separately for both type 1 and type 2 diabetes. Do not ignore the effect of exercise. If you look at the latest drugs we have today, the A1C reduction we have is 1 to 2%. If you look at all the trials with all the latest drugs, the effect of lifestyle reduction goes from 0.5 to 2%. So do not ignore the effect or the power of that lifestyle change that you're doing. In both type 1 and type 2, we do have significant glycemic control that comes from exercise. So then you may ask me, a lot of people ask, is it aerobic? Is it resistance? Right? What do you need? Which is more important? Do they work independently? Here are a number of trials that I've put together for you. If you look at the central line, you'll see some of them are aerobic, some of them are resistance training. What they have shown is independently each of these has an effect on its own, but together it has a synergistic effect. So clearly every trial shows that exercise is beneficial whichever you do. So even if you do plain walking, which is aerobic, there is effect. But if you add it, you get a dual effect. So that's what they show overall. Now what about complications? In type 1 diabetes, the risk of complications has clearly been shown. So this is from the Findane study, which showed all microvascular disease comes down with whether it's retinopathy, neuropathy, etc., both for type 1 and type 2. So here's the data for retinopathy, which shows that at any level of BMI, doing that exercise, it prevents independently for nephropathy. I'm not going through each of these, but trial is there for every one of them, whether it is nephropathy, whether it's nephropathy, whether it's neuropathy. It's there both for type 1 and type 2. Most of these studies are in Western countries. We do have some data from India as well. This is cardiovascular disease. This is not at all new. We definitely know that exercise has the maximum benefit in prevention of cardiovascular disease. And how does it do that? It does it by affecting on the lipids. So brings down total cholesterol, LDL cholesterol, increase in HDL, decrease in triglyceride, decrease blood pressure, decrease in body fat. With the new obesity guidelines that have come, this is the single most important way to decrease and durable way of decreasing body fat. It strengthens bones. Sir was talking about before this osteopenia. So much of there is there in our country. Quality of life, sense of well-being. Now this quality of life is something people don't generally talk about. We as physicians only to give the drug and send the patient, right? But is that patient able to take your drug? What is the effect? Are your drugs being worse than the actual disease that they have? The quality of life is something that we as physicians should learn to start asking and dealing with. And one of the things that affects quality of life, especially in our country, is very specific to Asian Indian, is frailty. Frailty is something that we see. What does this mean? It means that these people have we don't know the exact reason why they have it, but they're thin, they're small, they're osteopenic, their muscle mass is small, and everything they have is kind of augmented, whether it is their microvascular disease, whether it is, so this frailty is it's due to sarcopenia, they have gait imbalance, all of these things. This is particularly high in our country. So we tried to assess how much frailty is there in the clinic. So to all people who are above 65 years of age, we gave the frailty questionnaire that AIMS released, okay, saying that, do you think you are frail? These are questions, 10 questions you ask. Based on that, 70% of people said they are robust, no frailty. Okay, so people's perception was that they didn't have frailty. But then give them a hand grip dynamometer, which is an assessment of grip strength, your muscle strength. You give them that and see, absolute ulta. 60% of people are not just pre-frail, they are frail, really frail. Okay, so and if frailty is underlying any of your disease conditions, it worsens it by double, triple. So this was a definite learning for us. It was more in men here compared to women actually. And with degree of glycemia, the worse the glycemia, the worse the frailty. So what are the exercise recommendations? These are from the WHO. Please note there is a change in recommendations. Earlier we used to say 150 minutes of moderate to vigorous intensity activity for metabolic health. This has now been revised to 300 minutes of moderate to vigorous intensity activity. What does that mean? That means that if you walk for 1 hour, you should reach a distance of 5 to 6 kilometers. Okay, now this is something that people rarely achieve and is very, very difficult to. If they walk 1 hour, they'll do 2-3 kilometers maximum, whereas they should be doing 6 kilometers for metabolic benefit. For weight loss, the more the better. For older ages, multi-component activity is recommended because these people have, in addition to frailty, gait disorders, imbalance, reflexes slow down. So for them, moving in all directions, strength training 2 to 3 times a week is an absolute must. The only place where 150 minutes is still maintained is in pregnancy. Pregnant women alone, they allow this till 150. Everything else has been revised to 300. And the latest kid on the block is sedentary behavior. Limit sedentary behavior is the last red guy, you can see them. What is sedentary behavior? Sedentary sitting. So limiting this sitting has become very, very important. Now in those with diabetes and complications, how should you give the exercise prescription? If there is proliferative retinopathy, then there's risk for vitreous hemorrhage and retinal detachment. So avoid anything that will increase the strength of Valsalva. Okay, so anything with strength training, avoid there. Overt nephropathy, unless they're on dialysis, general walking and everything is perfectly okay. Peripheral neuropathy, the feet, again, here you have to be careful about two things. One is the footwear. So they may, get ulcerated and all with severe neuropathy, but otherwise they can do anything. Autonomic neuropathy, be very careful in our country. Extremes of temperature, sudden drop and death may happen. So you need to be very, very careful when you're giving an exercise prescription in severe autonomic neuropathy. Coronary artery disease, even 1 week after PTCA, it's okay to start regular activity at moderate intensity. Stroke, of course, you go into a rehab program depending on what the kind of stroke the person had. Peripheral arterial disease, again, you just have to be careful about claudication here. So if someone has claudication, that's the only thing you have to worry about. Even then, arm exercises, other exercises are fine. Precautions while exercising: stay hydrated. The hydration is really important. Proper footwear, proper clothing, and see that there is a warm up and a cool down before they start. If everyone starts running at the same time, then it becomes an issue. So slow build up. If someone is not at all exercising, even if they do 5 or 10 minutes of walking is great. Increase to 15, 20, 30 over time. That is the best way of doing it. In those with type 1 diabetes, always carry a carbohydrate snack. About 250 grams of carbohydrate is like a banana, easy to understand, or a thing of fruity. If they check the sugar, it's above 200, 250 or 300, do not exercise, miss that session. Or if it's below 100, again, be careful, give a carbohydrate load. Now, what are the barriers to exercise? There are plenty of barriers to exercise. No time, it's too cold, too warm, etc., etc. Women in white have much more exercise. We know that they have the least physical activity. So what are the ideal interventions for physical activity in women? It has to be interesting, it has to be fun. For a woman to actually exercise, it takes a lot. So we came up with this thing called as Tandav. Sir was asking about dancing. It's high intensity dancing, and this is what it is. Is a novel concept of physical activity aimed specifically at women and girls. So what is it? It is a concept which combines high intensity interval training, which is a certain type of exercise in which you do high intensity exercise for short periods of time and get all the metabolic benefits that you would get with a longer period of activity. So that's high intensity interval training. If you combine that with dancing, this concept is called as Tandav.
The Tandav dance routines generally include Indian film music, folk songs, regional music, and some Western songs that South Asians generally vibe to.
It essentially is high intensity dancing. It's simple, it's repetitive, the choreo is very innovative. And why is it very special? Because the minute you say dancing, it brings a smile on the lips of most people. People connect with music, and then you start having this whole feeling of wanting to do this exercise. Ladies and gentlemen, that was Tandav. So it's a first of its kind in the world, aimed specifically at women and girls. There are weekly sessions. There's a QR code there. If any woman is interested in joining, you're welcome to do so. Our classes are on Friday evenings. We have online and offline. So I'd like to conclude by saying that physical activity is rampant all over the country. We need novel ways of improving physical activity in both men and women in order to get metabolic health. Thank you so much.
Thank you, Dr. Anjana.